in particular Women's and Children's Health Research Unit. So I will be, during the next 15 minutes, I will be speaking about MNH registry, how we established the registry and its utility. The outline of my presentation is the origin of global network, registry's objective, study area profile, the process involved in establishing the registry, which includes three important components, namely household survey of married women of reproductive age, tracking system, monitoring, the current status, the utility of the registry, and the lessons we have learned over the time. The global network origin in 2001. The Global Network for Women's and Children's Health Research was conceived as a unique public-private partnership between National Institute of Child Health and Human Development, that is NICHD, and the Bill and Melinda Gates Foundation in response to the alarming rates of morbidity and mortality in women and children and the lack of research expertise and infrastructure in the developing world. It was the time when MDG, Global Maternal, MDG, Millennium Development Goals were established during that year. The network mission include sustainable research infrastructure, implementation and evaluation of evidence-based health interventions, and pertinent formative and translation research studies collaboratively, and to strengthen international collaborative research arrangements that focus on the leading causes of morbidity and mortality in pregnancy and early childhood. So, it is interesting to note that the first common protocol implemented by NICHD Global Network is first birth study. In that, it was a cluster randomized trial of training birth attendants in neonatal resuscitation to impact population-based perinatal outcomes. One of the component was to record the pregnancy outcomes happening in a defined geographical area. That time there was no registry. As a result of that, we developed registry system, that is pregnancy tracking system. This study was conducted, first birth study was in 2005 and 8. That necessitated the pregnancy tracking system to capture outcomes of deliveries occurring within clusters. NIH and Global Network started this pregnancy MNH registry from 2005 till 2000. It started from 2008, and currently it is going on. The objective of MNH registry is a prospective population-based observational study to quantify the maternal and neonatal health outcomes in the global network sites of National Institute of Child Health and Human Development, USA. Registry expanded in 2008 to enroll and follow up all pregnant women residing in the clusters and their newborn to 42-day follow-up. This is very, very important, enrolling all the pregnant women in a geographical area and following them till 42 days after end of pregnancy. It is conducted in 100 study clusters across GN sites. Over more than 500,000, almost 525,000 mothers and their infants enrolled to date. This is very important. More than 99% of the dyads have 6-week outcome stress. This is the first of its kind MNH registry, which has got data of almost more than 500,000 pregnant women and their outcomes. The maternal outcomes include maternal mortality, stillbirth, neonatal mortality, measures of healthcare, and maternal near miss. This we started from 2014. As the maternal deaths have come down, to reduce the further maternal deaths, to capture the near miss events of a pregnant woman is very critical, and the World Health Organization as of late has started this auditing of all the near miss events in order to reduce further the maternal mortality. So we have started this registry in Belgaum site in 242 villages covering a population of 723,795 population. So this is the area profile. This is Belgaum district having 10 blocks and Bagalkot district having 6 blocks. We have selected 20 clusters here in Belgaum district and 4 clusters in Bagalkot district. The distribution of clusters is such that it represents the entire district. That is the significance. So to begin with, our registry starts with survey of married women of reproductive age. We have adapted this system, household survey, from the existing reproductive and child health eligible couple survey of Ministry of Government of India. It is household every year in the month of December, November and December, household survey is conducted by our Ashas, which they cover a population of about 1,000 population and about 250 households. That is assisted by registry administrators and assistant registry administrators. They enroll married women of reproductive age between 15 to 49 years. They will identify those who are currently pregnant, those who are unlikely to conceive, and those who are likely to conceive. Ultimately, what we want is this one for the next year, currently pregnant and likely to conceive. So we collect simple but very effective information during the survey. All these things, we have minimized the information of collection in order to maintain the accuracy of the information. So this is for the year 2016. We have surveyed about 64,000 households covering a population of 345,000, and the family size is about 5.4 per household. Married women of reproductive age, childbearing age is about 62,000. It works out to 180 per thousand population. These many numbers, about 73.7% of the women are not going to conceive during the next year. Women who are likely to conceive is 26.3. Out of that, we expect 7,554 pregnancies during 2016. Again, this is validated by couple protection rate, birth rate. This is for the year 2015. We anticipated 7,896 pregnancies to occur during 2015, but actually we captured 8,203. There is about 400 increase. We have actually enrolled 400 women, more than our expectation. This is because during 2015, another 2,000 married women of reproductive age entered our study area and they conceived. About 400 increases there. So this is a very accurate method of estimating the expected pregnancies during the next year. So once we do the household, we very strictly monitor the entire process. Under this enrollment status, mortality rates, tracking pregnancy outcomes, adverse pregnancy outcomes, key variables, process measures, and error resolution. So this quality monitoring is published in a Reproductive Health Journal last year, 2015. You can follow this in this journal, already published. So this is the status from 2008 till January 2016. We have enrolled 528,000. We have captured almost 99% of the follow-ups. In our site, almost 100% follow-up is there. This is unique of this registry. Every pregnant woman enrolled is followed till delivery and 42 days after delivery. And this is very interesting. This is for the year 2015. This represents we consented 8,340 women, and their gestational age at enrollment. This one, almost 82% of the pregnancies are enrolled during the first trimester of almost 82%. This is nulliparous woman who conceived for the first time. It is almost 82% for 2015. This is going to be very critical for our next study, that is preterm birth prevention study or the aspirin study. So this is, since early registration is important, over the time miscarriages and MTP rates are going up. Here we will have to strengthen early enrollments in these three sites. These two findings, low birth weight and preterm births, are very critical, and in a community setup, I think this is the first time globally we have got the low birth weight rates and preterm birth rates. Across the globe it is 12.18%, and in our site it is 11.4% and 23.6%. So over the time we are collecting the stillbirth rates, early neonatal mortality, and maternal morbidity. Over the time stillbirth rates have come down, neonatal mortality also has come down, and maternal mortality. What remains is early neonatal death rates. See, this is facility births and perinatal mortality of Belgaum and Nagpur. Institutional deliveries have gone up from 2010 to 2013, almost more than 95%, and these are the perinatal birth rates. This is skilled birth attendance rates also have gone up during the last 5 years. And because facility births have increased, there is increase in the number of cesarean section rates from 9.9% to 18.6% in Belgaum. At present it is around 20%, and Nagpur it has increased from 17.6 to 23%. This is the maternal mortality. Over the time there is a significant reduction in maternal mortality rates. The observations include increase in facility births and skilled birth attendance are accompanied by reductions in perinatal and maternal mortality rates. Most reduction in PNMR is due to reduction in stillbirth rate. We shifted the place of birth and the birth attendance. As a result of that, stillbirths have come down. That is, SBR without a reduction in NMR may be attributed to increase in rates of cesarean deliveries. We trained birth attendants in these two, helping babies breathe. As a result of that, basic newborn care and resuscitation program, Navjat Shishu Suraksha Karyakram, Government of India adopted in 2010. As a result of that, stillbirth rates have come down, and the perinatal mortality due to stillbirths have come down. So what remains now is early neonatal deaths. Essential newborn care and HBB have definitely brought down newborn deaths due to infection and asphyxia. We have almost improved on that. But what remains is low birth weight rates due to small for gestational age and preterm births. Small for gestational age, we have already started one study, preconception maternal nutrition. In the afternoon or tomorrow you will come, that will be explained. For preterm birth prevention, which is very critical for preventing the low birth weight. That study is, we are going to start probably in 1 or 2 months. We are awaiting approval from the approval authorities. So what remains now is prevention of preterm births. That is most critical for achieving the goals by 2030. So what are the utility of the registry? It definitely provides population-based indicators of adverse pregnancy outcomes, their causes and trends over time. It permits assessment of maternal and newborn care practices in communities and facilities. It helps plan interventions to address mortality and morbidity unique to sites, enables capturing the outcomes of the cluster randomized trial. In the afternoon and tomorrow, you are going through all those cluster randomized details of cluster randomized trials. What we have learnt is, this system was there since many years, but we have simplified the entire process of early identification and enrollment of pregnant women by developing this method, likely to conceive, and limit the data collection to key variables to ensure the quality. One of the most important aspects is regular monitoring and supportive supervision and periodic refresher training, which we are carrying out since 2008, will definitely help the quality of the registry. We are paying a small incentive to ASHAs for tracking the likely to conceive as well as the pregnant woman and the woman in postnatal period. Encourage health workers to capture and report adverse pregnancy outcomes honestly and accurately. This is very important. And MNH registry model can form the basis for National Vital Registry System. And this also can strengthen the existing Government of India system of mother-child tracking system. So all these publications are published in Reproductive Health Journal. This is this one. So what I want to say is, simplify the entire process. MNH registry is the basis for establishing the evidences and testing the evidences for reducing the neonatal deaths, maternal mortality and morbidity. Next. Thank you. Thank you very much for presentation.